Welcome to the Speaking of Women's Health Book Chapter Podcast. I'm your host, Dr. Holly Thacker, and I am back in the Sunflower House, and we are going over my Cleveland Clinic Guide to Menopause. Today is Chapter 2, Symptoms of Menopause. When they approach midlife, some women suddenly find themselves lost in an avalanche of debilitating symptoms that daily threatens their quality of life. Depression, anxiety, sleep loss, you name it. Menopause or perimenopause can barrel into their lives like a runaway truck, affecting appearance, mood, sense of self-worth, sex life. That was Kathy's predicament, and it might be yours too. Kathy said, "Everything in my life was falling into place like a Kodak moment. My two beautiful daughters announced their engagement, and our family, always so close, felt complete. We celebrated with gatherings whenever possible, and my career allowed me more freedom to pursue hobbies I had to put on hold for years, especially gardening, which I really love. My husband and I even planned a post-wedding cruise, anticipating the need for a break after a hectic year. And the vacation would also serve as a second honeymoon for us. Our album of pictures from that year shows photographs of me smiling, beaming, picture perfect. I don't know how I held it together, because many days I didn't. Kathy is just not Kathy," my sisters confided to each other. And they were right. My period stopped, my body had abruptly changed, my panic attacks were unpredictable and uncontrolled. Frighteningly, at night, a racing heartbeat shook my whole body. My legs and arms would go numb as I imagined myself in a wheelchair, my life crashing down around me. I headed to more than one emergency room, and I consulted several doctors. Of course, my husband Bill loved me, comforted me, and held me. He knew I wasn't getting better, and neither of us could pretend differently. I couldn't sleep, which made everything worse. I was still smiling and trying to hold it together for my daughters on the outside, but I felt like I was falling apart on the inside. How could a mother and wife be so distressed and feel so desperate during what was supposed to be the happiest time? I finally visited a physician who specialized in women's health. After completing a history and exam, gynecologic evaluation, hormonal assessment, and a series of tests, she determined my symptoms were associated with hormone fluctuations, the onset of menopause, and panic disorder, all treatable conditions. "You're kidding," I said to her. "Unbelievable. These symptoms were not just like the classic hot flashes I had heard about." Well, on a scale of 1 to 10 for menopausal symptoms, Kathy's case pushes the limit. Her situation is somewhat unusual, although no woman's experience, while her reproductive system winds down, could be classified as, quote, normal. This goes back to my point that every woman is different. One woman might breeze through without many symptoms, not even realizing she's officially, quote, in menopause, until she counts off 12 months of menstruation-free months. Ta-da! A seamless transition. Her life is barely affected by the so-called change. Another one may suffer quite a bit, the way Kathy did, until she received proper treatment, that is. Menopause is natural. During this time, it is important to remember that menopause is a natural part of aging. It isn't a disease. However, just like with menstruation and childbirth, an educated assessment and some medical attention may be necessary. Many of my patients nearing their early 50s regard the years leading up to menopause, also known as perimenopause, as a living hell, but they don't need to be. If your symptoms make you feel like the shell of the person that you were just months ago, you're probably wondering, why me? The answer to this question is multifaceted. First, we must understand what happens inside of a woman's body during the months of menopause at the onset. Because menopause can vary with every woman, knowledge is the best tool for helping to maintain a positive attitude. So what's the inside story? A woman's life can be divided into 3 hormonal phases, comparable to the acts in a play: the reproductive phase, the perimenopausal and menopausal phase, and the postmenopausal phase. The pituitary gland in the brain is the director. It tells the body how much of certain hormones to make in each of these 3 phases. Furthermore, current medical thinking recognizes what most people refer to as, quote, menopause is actually a process involving 3 stages: perimenopause, menopause, and postmenopause. So you may ask, what is perimenopause? During this period, ovarian function can become more erratic. A woman may detect physical signs such as hot flashes and irregular periods. Perimenopause can actually be worse than menopause, and it can last for a few months to several years. We still say you're in perimenopause during those 12 months of lack of period, and then we look back and say, oh, that was the moment you entered menopause, your final menstrual period. So what is menopause? Well, it's that time when there is no more eggs left and you have no more cycling, no more periods. Now, for most people, it's between the ages of 45 and 50 that you have your final menstrual period, but really any time between 40 and 60 can be the range. A general indication of menopause is the cessation of periods for 12 consecutive months. And the average age for most women in this country is 51.3 years. Fast fact: the term menopause comes from the Greek meno, meaning month, or pausis, meaning to stop. Now, I've done research in the field of menopause, and I can tell you that there's some women who do fit the classic definition of menopause, and then you start treating them with hormone therapy and they start to feel better. And then if there's any ovarian reserve or activity, it might kick in and cause some abnormal bleeding, which still needs to be evaluated. But I think our concepts and ability to diagnose menopause aren't quite as precise as we would like. What is postmenopause? Well, the postmenopausal time frame is generally divided into an early phase, like the first 5 to 6 years since the last period, and then late postmenopause, which is beyond that time. And the early postmenopausal frame is the most critical in terms of symptoms and bone loss. And it's generally the time frame that hormone therapy is initiated if indicated. You cannot base medical decisions solely on chronologic age, because you could be a 55-year-old woman who's 10 years past menopause, already in your late postmenopausal phase, or you could be a 55-year-old woman still menstruating, be premenopausal, and even potentially still fertile. Or you could be starting to skip your menses and be in what we call perimenopause, or the menopause transition. Now, not to confuse you or get too technical, but the early menopause transition usually means you've only skipped a period for 1 or 2 months, and the late menopause transition means you've gone more than 2 months without a period. If you go more than 6 months without a period and then bleed, and you're over 40, that's technically abnormal. Even if you think it was a normal period, we still must evaluate. So, what's causing all of this change? Well, our levels of estrogen, testosterone, and progesterone, the main characters in our cast of hormones, fluctuate throughout our lives. And this up and down process sometimes produces happy endings. At other times, the hormonal imbalance can create conflict and the plot thickens. Estrogen. Well, that is the term for a class of female sex hormones secreted by the ovaries. There are 3 kinds of estrogen. Estradiol, or E2, the strongest and most potent. Estrone, E1, or estriol, which is mainly made in pregnancy, E3. And estrogen influences the development and maintenance of typical female sexual characteristics, like the female body fat, smoother skin compared to men. Estrogen also influences the female reproductive system in many ways, including primarily preparing the body for reproduction. Progesterone is a steroid hormone that prepares the uterus for pregnancy, maintains that pregnancy, and promotes development of the mammary breast glands. And the main source of progesterone is the corpus luteum, which is formed in the ovary after an egg is made, and it's also made in the placenta. The term progestogens encompasses both progestins, which are synthetic versions of progesterone, as well as progesterone itself. Testosterone. That affects sex-related features and development. In men, it's produced in very large amounts by the testes. In both men and women, testosterone is also produced by the adrenal glands, and in women by the ovaries. And even though men generally have 10 times the testosterone we women have, we women actually on a gram per gram basis have more testosterone than estrogen. But in women, estrogen plays the lead. So let's focus for a minute on the key hormones that signal menopause onset. Our leading lady, estrogen. Before a woman goes into menopause, more than 90% of her estrogen is made by the ovaries, organs that make a smaller amount, including the adrenal glands and the liver and the kidneys. Estrogen regulates your monthly cycles of ovulation and menstruation, and it plays a role in psychological well-being, including sleep and mood and sex drive, status of your urinary tract, skin, vaginal tissues, your bone, and heart. In addition, estrogen is involved in your blood vessel tone and the health of your gums and teeth and eyes. Historically, estrogen has been, quote, typecast as the girl's only hormone, regarded for its role in women's reproductive functions. And it's applauded for helping to bring babies into the world and for creating women's attractive hourglass figures. And sometimes it's blamed when those figures keep us from fitting into our favorite jeans. So estrogen seems to be all women. And like women, estrogen has a brainy side. Estrogen affects the brain's blood flow. It can boost verbal memory, whereas testosterone helps support spatial three-dimensional memory. Estrogen improves the way the brain processes information. Estrogen can affect the mood. For example, decreased estrogen levels can lead to lower serotonin levels, which can in turn spark anxiety or depression. And this explains why a woman with no medical history of depression may go through about just as she enters into menopause, particularly if she's had a long and prolonged and difficult perimenopause. We know that estrogen supports neuronal cells, and lack of estrogen can accelerate loss. Fast fact. It's ironic that the average 55-year-old man may have a much higher estrogen level than the average 55-year-old woman. And that's because men enjoy a steady production of testosterone as they age. And testosterone is converted into very small amounts of estradiol estrogen. But a woman suffers from decreased estrogen production abruptly as she enters menopause. So once a woman loses her eggs or her ovaries, she no longer has that source of estradiol production. And in general, estradiol levels, depending on the lab, can fluctuate from a low of 30 on the first day of the menstrual period up to 400 during menstruation. And during pregnancy can reach into the thousands. Now, a man who's much older than a typical menopausal woman, he can have an estradiol level of 40 or even 50. And usually we need a low menstrual level to help maintain bone health. So I think that fact alone is what stimulated me to be interested in menopause from a medical and physical, hormonal, psychological, and second half of life function perspective. And really how a woman is handled and how she's treated and what she does at midlife really charts the second half of her life. So, what are some of the short-term symptoms? Well, when your ovaries stop making estrogen and you go into menopause, hooray, your periods end. So for all intents and purposes, estrogen has exited the stage. But as we have seen, estrogen isn't only involved in your reproductive system. Other body systems are affected by estrogen. So It's easy to understand why menopause gets its tentacles into so many areas of your physical, mental, and emotional function. Unfortunately, we don't always realize how important estrogen is in maintaining physical and mental balance until we're running on empty. Then strange symptoms can suggest that something has gone wrong. So here's a list of some common menopausal symptoms. Hot flashes, sudden sensations of heat that spread from the chest to the head, followed by sweating, cold, shivering. A hot flush is not the flash, but it's the redness and that occurs in the neck and face. We'll talk a little bit more about hot flashes in Chapter 7. Night sweats. Hot flashes that can occur during sleep and cause perspiration. Difficulty sleeping is often related to hot flashes and night sweats and tends to happen more in the evening, which can then disrupt your normal circadian rhythm. Vaginal changes can include dryness and increased vulnerability to bladder infections. Sex drive. Mood changes can affect a woman's interest in sex. So can vaginal dryness, making sex more uncomfortable. Mood changes can include irritability, anxiety, and mood swings. Skin changes, dryness, itching, loss of elasticity. Headaches and migraines may be worsened in perimenopause with hormone fluctuations. Usually, migraines get better after menopause. And we have a lot of information on our website, speakingofwomenshealth.com, on migraines. Heart palpitations. These can be manifestations of symptoms such as hot flashes in the autonomic nervous system, which are the nerves and muscles that cause the blood vessels to constrict or dilate. Any heart symptom first needs to be checked out by a doctor before being simply attributed to menopause. Hair. Increased facial hair or thinning of the hair on the head can be due to a lack of estrogen and or increased sensitivity to a woman's remaining testosterone. And if androgenic alopecia, male patterned hair thinning, runs in your family, as a woman, you're not going to go bald, maybe like your brother, but you certainly can have significant hair thinning in the temporal areas and the top of the head. Memory loss or poor concentration. Forgetfulness or reduced ability to think clearly can be related to hormone fluxes, lack of sleep, increased stressors, undiagnosed other medical problems, vitamin deficiencies, or depression. Age-related changes. For all women, aging and menopause can go hand in hand. So naturally, the estrogen loss at menopause can be linked to other health problems that are considered common signs of aging. After menopause, women are much more likely to suffer from changes in bladder function, which can be age-related or genetic predisposition. Childbearing trauma, weight gain can all affect the bladder. Bladder function can be more overactive with the loss of estrogen, leading to thinness of the detrusor area, lower part of the bladder. Poor brain function, which can include an increased risk of Alzheimer's disease associated with advanced aging. Loss of skin elasticity, resulting in more wrinkling. Decreased muscle tone and bone loss. Changes in vision. Slower metabolism with weight gain. Some women feel defeated when they confront these issues. We can't stop the clock, after all, but you can control many of these problems with relative ease. Eating well, exercising, protecting the skin from sun damage, taking appropriate amounts of vitamins and supplements, staying actively involved in life as you work with your physician to design a personalized regimen. And we're going to talk more about age versus hormones in the next chapter, Chapter 3. So long-term problems. There are some long-term risks that women can inherit with age and menopause. Heart disease and osteoporosis are two of the most serious. The heart and bones can suffer tremendously from estrogen deficiency, making it especially important to take measures to reduce your cholesterol, lower your blood pressure, refrain from all smoking, nicotine, tobacco, and work to maintain your bone mass. Fortunately, lifestyle choices can modify these risks, and we'll discuss these and other ways to reduce your risk throughout this podcast. Are we there yet? Estrogen doesn't usually vanish from your body all at once without a warning. You do get some warnings in perimenopause, and the fluctuation and decline in estrogen levels start then. And this is the phase before full-blown menopause. During perimenopause, hormones begin to go up and down. Your periods may get heavier, closer together. Bleeding might get heavier. And periodically, hormone levels can surge, making you have breast tenderness, irritability, and the up and down levels can trigger hot flashes and night sweats. Perimenopause usually begins in a woman's 40s, and it can last as long as a decade or more. It does not mean over this entire period you'll notice all these signs and symptoms of menopause. It simply means that your ovaries are starting to wind down after all those years of ovulating. In fact, you might not recognize any of the short-term symptoms that we've discussed until you reach the last few years when estrogen production drops much more precipitously and dramatically. Perimenopause does last until menopause, when you finally run out of eggs. Well, how can I tell if I've reached menopause? When a woman stops having her menstrual period and hasn't had one for 12 months, this is usually defined as menopause. We will talk more about breakthrough bleeding and abnormal uterine bleeding in Chapter 13. How old you are when you experience menopause is related to the number of eggs in your ovaries, which is primarily determined by a genetic component. If women in your family generally go into menopause in their early 40s, chances are you'll experience an earlier menopause too. If women in your family had a very late menopause, like in my family, it's more likely that you'll be much later. Your lifestyle and medical history also affect the age you'll be at when you go into menopause. For example, smokers, women with chronic illness, depression, seizure disorder, are more likely to experience early onset. Women who've undergone radiation, chemotherapy for cancer treatment generally have earlier menopauses. In certain cases, women may enter menopause without knowing it and can even experience induced menopause.
We'll be back after a quick break.
Hey, quick question for you. Are you someone who wants to be fit, healthy, and happy? And what if I told you you could get your dream body by simply just listening to a podcast? I'm Josh.
And I'm KG, and we're the hosts of the Fit, Healthy, and Happy podcast.
Listen, we get it. Fitness isn't easy. Carbs, no carbs.
Just stop, okay? It doesn't have to be that complicated. And that's why we made this podcast. We get straight to the facts so you can become your best you.
So the way to check us out is click the link in the show notes or search Fit, Healthy, and Happy podcast on any of the major podcast platforms. We'll see you soon.
Pause. So a lot of women ask the question, can I be tested for menopause? Everybody wants a simple menopause test, something that will predict exactly what will happen. But unfortunately, testing for menopause is trickier than just checking your body temperature or checking your blood pressure or doing a culture for strep throat. A red flag. If a woman is over 50, has gone 6 months without a period, which is an indication of menopause, and then she bleeds or spots, she needs to see the doctor within a month. This kind of postmenopausal bleeding is caused by treatable and relatively benign conditions most of the time. But in some cases, 1 to up to 5% of the time, postmenopausal bleeding can indicate uterine cancer or some precursor to that, such as hyperplasia. If you do experience bleeding or spotting, you really should get an exam, a pap smear if indicated, perhaps a pelvic ultrasound or saline infusion sonography, as well as an endometrial sampling, at which time the doctor or nurse practitioner takes a small sample of the lining of the uterus, usually with a little 3mm pipelle or gyno sampler. We will talk more about abnormal bleeding and what to do about it in Chapter 13. So the best way to confirm menopause is by analyzing symptoms associated with estrogen deficiency, performing a thorough history and physical exam, including determination of your menstrual pattern, including when you started your period, what your menstrual history was like, the number of months you missed your period, as well as when did the appearance of classic symptoms like hot flashes occur. Assessing the status of the vaginal tissue, the major indicator of menopause, can be revealed in the condition of the vaginal tissues, which are very sensitive to the loss of estrogen. You have the most hormone receptors in the lower half of the vagina, the vulva, the urethra, and the base of the bladder. So normally the vagina is thick and plush and pink. But when your estrogen level dips, like postpartum when breastfeeding, like in perimenopause and certainly menopause and postmenopause, the vagina can become thin and pale and flat and dry. The pH of the vagina also goes up and it becomes more alkaline. And if the tissue is really thin, it might appear as red actually, and could even tear or bleed. Measuring the bone density and bone tissue. Bone is also very sensitive to levels of estrogen and other hormones, and it might show loss when estrogen production decreases over time. So half of all women have hot flashes, half don't, and half of all women over 50 lose bone, and half don't. And 80% of women can have significant changes in the vagina and the bladder with menopause. Still, many patients insist on a simple black or white test result, and many physicians will order blood tests while offering just a momentary snapshot of the various hormone levels. They can't really predict or completely diagnose or predict menopause. So the following tests are not particularly accurate ways of confirming menopause, and they don't necessarily tell you the total body estrogen. But these are some of the tests that women ask me about. A pH test. Well, when estrogen falls, the pH in the vagina increases and becomes more alkaline. So it's pretty easy to measure the pH level in the vagina with pH paper in the office. But this is certainly not any kind of a foolproof confirmation of menopause because many vaginal infections can cause the vaginal pH to rise, such as bacterial vaginosis. Saliva test. Well, your saliva or spit contains a fraction of the hormones that are in your bloodstream. Most salivary tests really are just a waste of money and are not a valid way to measure progesterone or estradiol, which is the most potent form of estrogen in the woman, and testosterone. And even when we do know a woman's level of estradiol, we can't predict when she's going to run out of eggs and lose most of her estrogen production. In addition, cigarette smoke, certain foods, hormone therapy, hormonal contraceptives, environmental stressors can affect the results of salivary hormones. And really, the only validated salivary hormone is cortisol. Urinary test. Well, urine tests promise to give an indication of menopause onset, and they can be generally purchased without a prescription for home use. And these urine tests generally measure pituitary gonadotrophins, which are typically quite elevated in menopause. Again, these tests are not always reliable because they can elevate during the years before menopause, during ovulation, so it could be as long as 10 years later until menopause begins. And be aware, even with elevated urine tests, if you've not gone 12 months without a period, you could still be premenopausal or perimenopausal and still at risk for pregnancy. Follicle stimulating hormone, FSH. Measure the blood level of follicle stimulating hormone, which rises each month to encourage the follicles to release an egg from the ovary, which then, if not fertilized, results in a menstrual period. So a very high FSH level may indicate that your body's working really hard to try to release the egg and might not be so successful. But depending on how high the levels are, this could possibly reflect perimenopause or menopause. But the FSH levels can really fluctuate from 1 minute to the next, making them unreliable predictors of menopause. The test is usually ordered within the first 3 to 4 days of the period in the follicular phase, when levels tend to be their lowest. And they can also be used in infertility evaluations to assess ovarian reserve. So generally in the follicular phase, if your FSH is over 10, we're concerned about your fertility. If it's over 20 rather, we're concerned about perimenopause. And if it's consistently over 40 over several months without menstruation with typical symptoms in the right age, it's getting closer to being able to diagnose menopause. So many doctors simply order these tests because they want to have something, but unfortunately they're not predictive or definitive. Now, anti-Mullerian hormone, which is sometimes used in fertility practices to gauge the ovarian reserve, there is a PICO AMH, so-called menopause test, but many labs and hospitals don't order this. So this is a test that I get more likely if I'm doing an evaluation for premature menopause or premature ovarian insufficiency, which can occur in 1% of women under age 40. So are the menopause and estrogen-related tests reliable? Well, ultimately body fluids, whether it's your blood or saliva or urine, are just simply not the most accurate way to measure total overall estrogen levels in a woman. And metabolism is very complex where estrogen is concerned. A woman may have a low level of estrogen in the blood, but very high levels in certain body tissues. So what's inside your bloodstream or saliva is not as important as what's inside the body tissues, such as the brain, the breast, the bones, reproductive and urinary systems. Alone, these tests cannot solely diagnose menopause. But if they're paired with an astute clinical evaluation, an exam, a bone density test, historical information.
We'll be back after a quick break.
Have you ever experienced fitness failure? You know, you set a goal to exercise, you're all excited, and then you're not. Hi, I'm Dave. I host the daily 10-minute podcast, Walking is Fitness. Instead of an exercise goal, I talk about making a fitness promise. And every day you keep that promise, you add another link to a growing fitness chain. This is a podcast of action. You'll create a fitness habit, which eventually becomes fitness momentum, and then on to all kinds of good stuff. Check it out. Walking is Fitness, and let's take a daily 10-minute walk together.
They can certainly serve as supporting evidence. And persistently elevated levels of FSH usually imply impending menopause. But I have seen women have elevated FSH levels for years and still have bleeding and fluctuating hormone levels. And I have seen women with exceedingly high FSH levels who are told that they probably can't have children, who then later spontaneously conceive. So you can see that this is vexing and frustrating, and it's not as simple as just checking a thyroid blood test or a blood sugar or a hemoglobin A1C that kind of reflects your blood sugar over the last 3 months. Now, a fast fact, premature menopause occurs in less than 1% of women under the age of 40. Reasons can range from autoimmune conditions to Fragile X syndrome to chemotherapeutic treatments. Question: does birth control affect menopause? Well, in addition to contraceptive use, I prescribe hormonal contraceptive agents, either pills, patches, or vaginal rings, many times to help alleviate the symptoms during perimenopause. But if you are taking any form of hormonal contraception, your periods won't tell you whether you're officially in menopause or not, because you will get a period if you withdraw the hormone, which is typical in pill packs of 4 days of placebo or taking out the vaginal ring for a week. So the only way to tell is to go off a hormonal contraception. But keep in mind, the timing of this experiment is really up to you. If you're dealing with several stressors in your life, it's probably not the right time to experiment with your hormone levels. Take, for instance, Valerie. Valerie was a 52-year-old patient of mine who asked me if I thought she should stop taking the hormonal contraceptive pill. She didn't need it for contraception anymore since her husband had had a vasectomy. However, she was finishing her master's degree, she was juggling a demanding career, and she was caring for her ailing and aging mother. So I asked her to consider whether this was really the best time to introduce another stress in her life. She decided to wait until she earned her degree. Of course, Valerie could have gone off the pill and felt just fine, but it was equally possible that if she did, her hormone levels would have proceeded to rage out of control or precipitously drop to very low levels. So, what is hormonal contraception? Well, today's birth control comes in a whole variety of forms, collectively known as hormonal contraception if it involves any hormones. First, we've had the pill, we've had the patch, vaginal ring, we have some uterine devices, and we have a subdermal under the skin implant. So, here's the bottom line. If you're on hormonal contraception and you do not smoke, you have a normal blood pressure and overall good health, you could potentially continue taking hormonal contraception until you're 55 or 56, depending on whether you need contraception and what's going on in your life, and picking the right time. Certainly, I always tell women to start to anticipate this. I don't ever just artificially take someone off of hormones because they're 51. I mean, half of women still can ovulate after 51. During this time, I talk about the symptoms of menopause so they understand what to expect. Some of them go off the pill and never have a period and suffer few, if any, symptoms. But many, after being used to years of complete perfect hormone control, can crash right into menopause with severe side effects. So if a woman comes off hormonal contraception and has difficult symptoms, I may put her back on it, especially if she needs contraception, or I'll prescribe hormone therapy, or sometimes we just pick a date to do the transition off hormonal contraception onto menopausal hormone therapy if she doesn't want to risk having any symptoms at all. Now, a fast fact is estrogen therapy is not risky for women who've had a hysterectomy and have menopausal symptoms. In fact, I am part of a nonprofit called AHA, Advancing Health After Hysterectomy. And you can find out more information about AHA on speakingofwomenshealth.com as well as menopauselearning.com. And our goal is to get the message out to women, doctors, the media, that if you're under 60, even 65, but certainly under 60, and you don't have a uterus, you should be on estrogen for the most part, because not only does it control symptoms, it reduces disease, and it prolongs life. And estrogen is associated with reduced risk of breast cancer even into your 70s. Now, if you have a uterus, it's a different story because estrogen does stimulate the lining of the uterus, and that's why we have to use progesterone to protect the uterus. So hysterectomy and hormone therapy. Women who've had hysterectomies don't have menstrual periods, but they can still make hormones if they have one or both ovaries. In a woman who's had a hysterectomy but has her ovaries, when her estrogen level falls, she can have symptoms of menopause just like any other woman, but she's not going to have changes in her menstrual pattern. Sometimes women who've had hysterectomies begin menopause a few years earlier because of disturbance to this very sensitive reproductive area. Women who've had both the uterus and ovaries removed during a hysterectomy are more likely to experience the immediate onset of menopausal symptoms because they abruptly go from producing estrogen to having no ovaries, no estrogen. This type of menopause is known as surgical or induced menopause, and it does tend to be more severe. Many women who've had hysterectomies ease into menopause without a problem. Without a uterus, most of these women no longer experience monthly bleeding or pain, and they generally enjoy fulfilling sex lives. But there's no absolutes. 1 out of every 6 to 10 women whose ovaries were removed during hysterectomy is thrown into a tailspin during menopause. Not only are her hormones out of balance, her body may be depleted of both estrogen and some testosterone. Hysterectomy with oophorectomy surgery can cause a woman to lose most or all of her estrogen and up to 25 to 50% of her testosterone source. For most women in this situation, hormone therapy is a very effective choice for the alleviation of severe symptoms. And there's many different ways to take it, including pills, creams, gels, sprays, vaginal rings, and patches. When physicians deny women in this condition the opportunity to take estrogen, it's like telling a woman who needs shoes that she should be able to get along with slippers or boots or just go barefoot. When women are shut out of proven options, like hormone therapy, which we've used for several decades, almost a century, we lose our freedom of choice and the ability to decide which solution is best for us. So you need a healthcare clinician who's knowledgeable about women's health, who presents all the options. And not all family physicians, OBGYNs, or internist or endocrinologist always keep up with the latest studies on hormone therapy. It's very individual. Doctors should know that estrogen therapy is not a risky solution for most women with hysterectomies. However, even medical professionals can be influenced by the media, and we know the media likes clicks, likes negative news, likes to induce panic many times. So if you've had your ovaries removed during hysterectomy, please be sure that you see a physician or nurse practitioner or physician assistant who is familiar with all therapy options. There is no reason for you to suffer. So, is menopause easier with or without ovaries? Well, a hysterectomy is a major surgery to remove a woman's uterus. It's often performed to treat a health issue like fibroids, bleeding, pain, prolapse, or even precancer or cancer. The procedure may include removal of other reproductive organs, including one or both of the ovaries, the fallopian tube, and the cervix. I recommend, if a woman is done with childbearing and is having any gynecologic surgery, that she always remove the fallopian tubes in total, because that reduces ovarian cancer. Many ovarian cancer starts in the fallopian tubes. And now, when we do tubal ligations, we don't just tie the tube, we actually remove the complete tube. And for women who have the BRCA gene or have a genetic predisposition to ovarian or cancer and are not yet ready for complete hysterectomy, many times if childbearing is completed, they will have the fallopian tubes removed. In general, I usually advise women to keep their ovaries until the age of 65, unless there's a good reason to remove them, such as disease, cancer, or the presence of mutations, such as the BRCA gene, as well as other breast and ovarian cancer syndromes. So if you are faced with those risks, it is very important for you to get the knowledge and the empowerment. And many times we wait until age 40 to remove the ovaries in high-risk women with BRCA2. But sometimes with BRCA1, we may even recommend it earlier. And some of this depends on the woman's history and her family history. So you have been listening to the Cleveland Clinic Guide to Menopause. We just finished Chapter 2. Thanks for joining me, your host, Dr. Holly Thacker, in the Sunflower House. And be sure to subscribe to our podcast. Give us a 5-star rating. And please be sure to join me for Chapter 3, What's to Blame? Age or Hormones?